Good morning, students. When you enter clinical postings, that is after completing anatomy, physiology and biochemistry, you enter these professor rooms or assistant professor rooms with a lot of anxiety. Sometimes palpitations, hearing your own heart sounds and feeling sweaty and somewhat breathless. So today our topic is about this breathlessness. There are two types. One is physiological breathlessness, that's what you feel because of anxiety. Second one is pathological breathlessness because of the structural diseases of our body parts. So the topic of breathlessness is known as dyspnea. In grand olden days of science, most of these terms are from either Greek or Latin because in those days Aristotle, Socrates, other scientists, they used to describe these symptoms. So in the honor of their legacy, the terms have been carried forward thereafter in our English literature. In those languages, dys means impaired. Pnea means pneuma, lung. So related to lung means breathing. So dyspnea is nothing but impaired breathing or labored breathing, which one is aware of. Usually we are not aware of our own breathing unless we are anxious, we are rushing for some food and we are fighting with each other, kind of those things. But when we are aware of our own breathing, especially in elderly individuals, means those geriatric people who come to our wards, postings, like that, you should suspect pneuma, that is lung. Any lung issue is there or not. So the most common cause of dyspnea is any condition affecting the lung, followed by God has created our human body like that. We have got two lungs, and among which we have got heart situated. So these are lungs. Any issues pertaining to these parts can lead to labored breathing or dyspnea. And down the line, God or a force created a structure separating these vital parts from the supporting parts. These are vital. So vital are heart, lungs, above that brain. But unfortunately, because of AA or this work is also diminishing. So what we are left over is this part, which nowadays compared to vital part, we are utilizing this as more of supportive part, especially by visiting restaurants, unnecessary eating, junk food, kind of all those things. So this beautiful structure which separates this known as diaphragm. Which is essential for breathing, other kinds like passage of vital structure from there to here. Any impairment of this function can lead to, again, same thing, dyspnea. So first one is lung, second one is heart, third one is diaphragm, and downstream we can see we have got lot of abdomen and structure inside. So what is the most common cause of abnormality related to abdomen nowadays? Because of overeating, obesity, means being overweight, more than 85th percentile that we are going to discuss in advanced sections. So anything in excess here, anything lesser here can lead to dyspnea. So fourth one is abdomen. Rarely but not least important is this one, because our brain regulates all these parts. So anything interfering with the respiratory centers, especially in the medulla, can lead to some sort of dyspnea. But on the other hand, they can lead to complete cessation of breathing, that is known as apnea, or something like Stokes breathing, CSB. That okay, we'll discuss in advanced sections. So as of now, this is sufficient. So remember students, the most important structures involved in pathophysiology of dyspnea are lungs, heart, diaphragm and abdomen. Okay. So coming to evaluation of dyspnea. So what is most important is that whenever a person comes to us, we have to talk to them. We have to discuss with them what are their problems. Here most important is listening, especially active listening. Nowadays, because of modern lifestyle or because of our addiction to screens, which shouldn't be there for more than 1 hour a day. So what they are discussing with us, what they are trying to emphasize, telling us, we have to listen. Listen, listen, listen. So this active listening is the cornerstone of your success in medical field, that is as a doctor. To be a successful doctor, you have to listen, not to go on talking. As our elders have told, we have got 2 ears and 1 tongue. That means you should listen twice as much as you talk. That is most important. So in this way, you can become a good doctor. So coming back to history taking. So active listening. Second thing is that observation. Observing the person or patient who comes to us. How they are walking. How they are talking. Means without any labored breathing. And how they are able to manage their daily routine. You can ask one by one. So in this setting, you have to ask like this. Please tell about your problems. So active listening, observation, and most important is asking open-ended questions. Open-ended questions means, please tell me about your problems, rather than you have got breathlessness, and you shouldn't use these technical terms like dyspnea with the patient. Tell me about your dyspnea, because patient might be hearing this word for first time, because as in the second year we are hearing this sentence, so they are not familiar with these things. So you have to ask open-ended questions which are applicable in their vernacular language to the patient. So with these 3 things, active listening, observation, open-ended questions. This is nothing but history taking. So please remember, as far as anything is concerned, not only dyspnea, history taking is important. Based upon your active listening, observation and open-ended questions. Till that, please don't touch the patient unless you are quite experienced and confident of yourself. So the second part is discussion about dyspnea. So by this time you are well aware of definition of dyspnea, labored breathing or impaired breathing. So there are so many scientists which have tried their hand in classifying dyspnea so that it will be useful for us. But rather than being more useful, it created a lot of confusion. One is Medical Research Council of UK in 1960s, and after that, as usual, the next generation doctors were not satisfied, so they modified it. It is Modified Research Council criteria in 1980s. This is on one side. Transatlantic, as US is always unhappy about others, they think that they know more than everyone on earth, so they devised their own classification, that is known as New York Heart Association classification. So both are essentially about dyspnea, but here the catch is this is more pertaining to lung problems, whereas NYHA essentially deals with, as term itself, New York Heart Association, cardiac etiology of dyspnea. So clear? This is about issues of lungs. This is about issues of heart. Both are classified in 4 grades with increasing severity. 1, 2, 3, 4. One is nothing, normal. Second is mild. Third one is moderate. Fourth one is severe or at rest also. Dyspnea is happening. It is applicable to both. So is it clear? So let us discuss one by one. This mild they are rated as normal variant, walking for some distance on level ground. Third one is after some 100 meters of walking or a slope or even at rest. Similarly, for this is normal, this is with moderate exertion, this is with minimal exertion, and third one is at rest, means not able to complete sentences. If somebody is not able to speak to you, there are mainly 2 issues. Either they might be loving you or they might be hating you. But as far as this is not able to complete sentences, so this is the thing we shouldn't miss. You may miss second, you may miss third severity, but one shouldn't never miss severe degree of breathlessness. Sometimes patients appear completely normal at rest, but while you are talking to them, when they are speaking, they may develop breathlessness. That one shouldn't miss. That means you have to listen more rather than talking. Make the patient active and make him or her your center of attention. That's it. So is it clear? This is Modified Research Council UK classification pertaining to lungs. This is an NYHA classification pertaining to cardiac issues. So students, so far we have come to know about what is meant by dyspnea, how we should take history pertaining to this classical symptom which is very common, and third one is classification. So one shouldn't miss most important thing, types of dyspnea. So what are various types of dyspnea? Number one is, most common is orthopnea. So ortho means, for example, in orthopedics patient who has got fractures, does he walk or does she walk? Most of the times they will stay on bed. Bed means supine position. So in lying down position, if somebody is developing breathlessness, apnea means related to lungs. In supine position, lying down means it is called orthopnea. Second one is opposite to that is known as platypnea. Platypnea means platy, while erect means while standing or sitting rather than lying down. If a person develops breathlessness, it is known as platypnea. Number third is trepopnea. Trap. All these are Greek and terminology. We not by heart, but with routine practice we can remember these things. Trepopnea means developing breathlessness when patient on one side. For example, if patient is being breathless while lying on left side, so it is known as left side trepopnea. If the patient develop impaired breathing or labored breathing while lying on right side, that is known as turning on one side, it is known as trepopnea, right side. Fourth one is Bendopnea, that is while bending forward. And fifth one is Paroxysmal Nocturnal Dyspnea. That means suddenly waking up from the bed at night times because of breathlessness, especially during REM stage of sleep, because of various. So types is, first one is orthopnea. Orthopnea is what we have discussed, is while lying down, that we can show in diagram. So what are those causes? Whatever those diseases, either in lungs or heart or down the line, what I have discussed, abdomen, they lead to congestion of these organs, they can lead to orthopnea. So most common causes of lung failure is COPD, chronic obstructive pulmonary disease, because of smoking. Second most common cause is for orthopnea, ischemic heart disease leading to heart failure. That means long-standing hypertension, high cholesterol levels, blocking the arteries, patient having lot of stents, not able to work. Still, in spite of that, if he or she is enjoying their life, it can lead to heart failure. Third one is associated obesity. So these three things, if you remember, it is more than sufficient for second year. So this is all about orthopnea. So let's go to opposite component. Platypnea is exact opposite to orthopnea. Means while standing up like this or while sitting, if I feel breathlessness, it is known as platypnea. It often happens in shunts. So what are those shunts? Usually we have got our body into left and right. Usually blood flows from the, comes here, right atrium, right ventricle, then goes to pulmonary circulation and then flows back to various spots. So from right side it is flowing. Some shunts are like that, they are open only in fetal life and they will close as soon as we are born. So instead of being closed like this, if they are still open, can lead to desaturation of the blood. Means previously as we discussed, instead of normal oxygen saturation of more than 95%, if saturation is less than 95%, definitely here there is an unhealthy problem. So with this unhealthy areas, if blood is flowing, it is going to bypass this oxygenation. So whatever we are deriving is this less oxygenated blood, that is also known as deoxygenation. So this less oxygenated blood can lead to dyspnea. So for more pathophysiology understanding, we can discuss in the later academic sections. So we have discussed so far about orthopnea, most common cause of dyspnea. Second one is platypnea. This is lying down. This is standing or sitting. So most interesting is third one, Trepopnea. You might have been thinking what this nonsense is. Trepopnea is nothing but in midway between these two. That means when a person is lying on one side, they become breathless, whether it can be on the left side or right side. So right side Trepopnea, left side Trepopnea. So trep means one side, pnea means related to lung or impaired breathing. For example, we shouldn't go into too much technical details. If a patient has got heart problem, say heart failure, so where heart lies, in 99% of settings it is on left side. Heart is on left side. So in heart failure, if the patient is lying on left side, what will happen? Furthermore, congestion will increase. So they tend to lie on right side, so that congestion comes down because of gravity. So if a person is lying on right side, especially who is having cardiac problem, suspect Trepopnea. It is also known as uncompensated heart failure. You can estimate its severity by doing a blood marker known as NT-BNP. It is a blood test that is available everywhere nowadays. Okay, we'll discuss about this later. On other hand, Trepopnea. If something, a fluid surrounds our lungs, constituted from the outside, say on left side itself assume, if the patient turns towards right side, this will entirely gravitate here and will feel more breathless. So the patient turns to left side, if it is a left effusion. So if left side heart problem is there, patient turns to right. On other hand, if the problem is in the left lung, like any water accumulation, that is known as effusion, patient tends to turn on the diseased side, left side. So in this way you can distinguish this patient is having either heart problem or lung problem. So again I emphasize, taking history is very, very important. So when you are taking history, you should be attentive to these details. Whether patient prefers to lie on right side or patient prefers to lie on left side. Okay, clear? Okay, we'll go to last type of dyspnea, that is the fourth one, that is paroxysmal nocturnal dyspnea, PND. PND is also actually related to lung and heart itself, but the problem happens during sleep. PND, paroxysm, sudden. Nocturnal means night. Dyspnea means breathlessness. Patient suddenly waking up from the bed, feeling uncomfortable, feeling breathlessness, and telling that I am not doing okay, and rushing towards window and trying to catch fresh breath of air. So in such settings, you have to suspect PND. So the patient might be having lung issues or heart issues, but we know sleep is not a homogeneous part. It contains various stages of sleep: light sleep, deep sleep, which are classified as REM sleep, NREM sleep. REM means rapid eye movement. If you observe your parents or your friends, if you are awake, sometimes they might be flickering eyes like this fast. That is known as rapid eye movement sleep, in which dreams do occur. What happens in dreams if they are terrorizing? Sympathetic system will get SNS. Sympathetic system will get overactivated. When sympathetic system is get overactivated, the person who is sleeping will get overexcited. On top of these lung and heart problems, he will feel breathlessness, so that he will wake up. Because of breathlessness, he is waking up. Not because of lack of sleep, he is waking up. So always again emphasize, taking history is most important. Which is happening first? What is first, what is second? Here, dyspnea lead to insomnia. This is dyspnea. On other hand, if insomnia leads to dyspnea, it might be psychogenic component, means the person is having any breakup issues or any financial issues or something other, so he feels or she feels anxiety, tense, so that they tend to wake up. So careful history taking often differentiates between this paroxysmal nocturnal dyspnea, which you shouldn't look over, and this psychogenic dyspnea. Okay, clear? We'll go to fifth one, that is last one, recently described. So let me erase this diagram to make it clear. So far we are clear, isn't it? Number one is orthopnea. Number two is platypnea. Number three is Trepopnea. Number fourth is just now what we have discussed, that is PND, paroxysmal nocturnal dyspnea. So orthopnea is supine. Platypnea means while erect, either sitting or standing. Trepopnea is in between, one side. Paroxysmal means sudden waking up. Fifth one is recently described one, that is known as Bendopnea. Bend means, fortunately this has been recently described, that's why it is having English name, Bendopnea, rather than some archaic Greek or Latin name, Bendopnea. Bendopnea means when a patient is sometimes while doing work or while sitting, if they crouches forward, means while bends forwards, suddenly what will happen? This entire abdominal condition will push up against our diaphragm. Already if lungs are diseased, they will get again constricted. So there will be congestion of lungs and heart. So what will happen? They feel breathless and they try to sit or stand up. Sometimes they will even collapse also. If they are trying to lean forward sometime while doing some work, while sitting on a stool, kind of those things. This is known as Bendopnea. So Bendopnea is also not something other, but in that particular position, if a person experiences dyspnea, it is suggestive of same thing, either lung or heart issues, either lung failure, what we call as most common cause is COPD, heart failure because of our hypertension, ischemic heart disease, kind of those things. So by this time you might be well aware that whatever the classification is, the most common underlying factors, that is we can say denominator is congestion in the thorax, either of lungs or heart. So always remember, whenever a patient is having dyspnea, look for these issues, lungs and heart. So with these things I would like to conclude today's topic, and if you can tell this enough to your professor, you will be more than happy. Any suggestions, please let me know. Thank you.